Welcome, curious minds, to the deep dive. Today we're embarking on a journey into something that touches millions of lives.
Mm.
Yet its complexities, the dangers lurking just beneath the surface, they often go unseen. We're talking about infectious complications from bites.
It's a fascinating and, frankly, important topic.
Did you know, just in the U.S., over 4.7 million dog bites happen every single year?
That number is staggering, isn't it?
It really is. It's not just a statistic. It translates to thousands of ER visits daily. And the infection risk,
Hmm.
it's often shockingly underestimated, sometimes life-threatening.
Absolutely. And it all starts with our skin, our largest organ, an incredible frontline defense.
Right?
It's this dynamic barrier constantly protecting us from, a world teeming with microbes.
But a bite, whether from an animal or maybe surprisingly another person.
It fundamentally breaches that defense. It's not just a surface thing.
So it's like an open door.
Exactly.
Hmm.
A direct pathway allowing microorganisms past that outer layer deep into tissues that are much more susceptible.
And that's precisely what we want to understand today, right? To get that mastery-level insight.
Mm-hmm.
This deep dive is grounded in a comprehensive medical text, Chapter 141, specifically on infectious complications of bites.
A really solid source.
Our mission, to unpack this critical material, go way beyond the surface. We'll look at the common culprits, the rare but severe outcomes.
And how doctors actually diagnose and treat these things.
Right, it's not just what bites, but what really happens afterwards. How can we as learners think like the elite professionals in this field?
It's about seeing those specific vulnerabilities, how our resilience can be compromised when that primary shield is broken, understanding that interplay is key.
Absolutely. So let's start there. Let's really appreciate the skin's crucial role. We kind of take it for granted, don't we?
We really do. It's just there,
Yeah.
quietly doing its job.
But what is that job exactly in terms of stopping infections?
Well, it's performing a Herculean task, truly, every single second. The skin is a fundamental part of our nonspecific immunity.
Non-specific meaning. It protects against everything generally.
Pretty much, think of it like the body's border patrol. A robust physical barrier stopping most potential pathogens, bacteria, viruses, fungi from ever getting inside.
Without it, we'd be constantly bombarded.
Constantly. It's a remarkably sophisticated defense, often underappreciated until, well, it's breached.
So when that barrier is broken, by a bite or even a deep scratch, it's much more than just a cut.
Far more. You could say it represents a direct form of immunocompromise.
Okay, explain that. Does it weaken your whole immune system?
Not necessarily your whole system, no. But it means that the critical physical shield your immune system relies on has been bypassed instantly.
Getting that direct pathway you mentioned.
Exactly. Microorganisms get inoculated, basically injected past the skin into deeper, more vulnerable tissues. Once inside, they can dodge those surface defenses and really set up shop. Start an infection, sometimes incredibly fast.
What's fascinating, and maybe overlooked, is how a simple puncture can create such a complex danger zone.
It really is.
It's not just the hole you see, it's the biology of that breach.
It's a powerful reminder of how finely tuned our defenses are, and how significant even a small compromise can be if it gets past those outer layers. It turns a simple event into a complex biological fight.
Okay, let's zoom out then. Look at the bigger picture of animal bites. We mentioned the millions of dog bites, but what's the overall annual scale?
The scale is immense. Really quite sobering when you look at the numbers. Millions of animal bite wounds happen each year in the U.S.
Millions.
And the vast majority, they're from our own pets, dogs and cats mostly. There are over 100 million of them in U.S. households.
So the odds are pretty high just based on exposure.
Right. The annual incidence is around 300 bites per 100,000 people. And while pets are the main source, we also see bites from wild animals, or in certain jobs.
Like vets, lab workers.
Exactly. Vets, wildlife professionals, even farmers. People who work closely with animals.
And while many wounds might look minor, that's deceptive, isn't it? A significant number gets serious.
That's a critical point. Some bites might just need basic first aid, sure, but a substantial number do result in infection.
And the severity varies hugely.
A whole spectrum. From localized issues needing minor treatment all the way to limb-threatening or even life-threatening conditions.
Oh, wow. And predicting that risk comes down to the microbes involved.
Fundamentally, yes. It hinges on understanding the microbiology. As a general rule, the bacteria causing bite wound infections largely reflect the oropharyngeal flora of the animal that bit you.
Okay, let's unpack oropharyngeal flora. So the main culprits are living inside the animal's mouth, not just on their fur or something.
Exactly right. Think of an animal's mouth as a bustling microbial city. Very diverse.
Different for each species.
Yes. Dogs, cats, rodents, humans, we all have a unique collection of bacteria living there naturally, both aerobic, needing oxygen, and anaerobic, thriving without it.
And a bite injects that whole cocktail deep inside.
Precisely. Not just on the skin, but often deep into tissues, bypassing surface defenses. Now, it's not only the mouth flora.
Oh, okay. What else?
Well, other organisms can get involved too. Bacteria from the soil if the bite happens outside, microbes from the animal's skin or the victim's skin, even from the animal's feces, maybe through grooming.
So it becomes a really mixed bag.
Often, yes. A complex polymicrobial environment, multiple types of bacteria working together, sometimes against each other.
Which must make treatment trickier. You're fighting multiple enemies.
That's exactly why it's challenging. You need broad coverage.
Makes sense. And speaking of specific animals, dogs are the big one, right? Our best friends, but also the source of most bites by far.
It's a striking paradox. In the U.S., dogs bite over 4.7 million people yearly. That's a massive 80% of all animal bites.
80%.
Yeah, and the medical impact is huge. An estimated 15 to 20% of those bites get infected.
That's still a huge number.
It is. 800,000 Americans seek medical help for dog bites each year. 386,000 end up in the ER. That's over 1,000 ER visits every day just for dog bites.
Every single day. That's incredible.
And tragically, about 30 deaths a year result from these injuries or their complications.
That really puts the seriousness into perspective. What's a typical situation for these bites? Is it mostly stray dogs attacking?
That's a common idea, but actually no. Most dog bites are provoked.
Provoked?
Yes, and often inflicted by the victim's own pet or a dog they know well.
Really? Like how?
A very common scenario is trying to break up a dog fight. You jump in and inadvertently get bitten in the chaos.
Ah, okay. So it's often during interactions, not random attacks.
Exactly. It highlights how important understanding animal behavior is, even with familiar pets.
And who tends to get bitten most? Are certain groups more at risk?
Definitely. Children are disproportionately affected compared to adults.
Dumb kids.
The highest rate, 6 bites per 1,000 people, is among boys aged 5 to 9. Overall, males are bitten more often than females.
And where on the body?
Most often, it's an upper extremity, hand or arm, but here's a really critical point.
Yes.
Among children under 4 years old, 2/3 of all dog bite injuries involve the head or neck.
Wow, 2/3. That's terrifyingly high, especially in that area.
Extremely concerning. Proximity to the brain, eyes, major vessels. The consequences can be much more severe.
So if an infection does take hold, what does it look like? What are the telltale signs?
Typically, it shows up pretty quickly, often within 8 to 24 hours after the bite.
What would the person notice?
Increasing pain at the bite site, almost certainly. Then cellulitis that's spreading redness, warmth, and swelling in the deeper skin layers.
Like the infection is spreading outwards.
Exactly. And often you'll see purulent discharge, basically pus, maybe foul smelling.
And it can get worse locally?
Oh, yes. Serious local complications can happen if a tooth penetrates deeper structures, like a joint lining the synovium or the bone itself. Septic arthritis, a joint infection, or osteomyelitis, a bone infection. Both are much harder to treat and can cause long-term problems.
Are there signs the infection is spreading through the body?
Yes, systemic signs can occur. Fever, swollen and tender lymph nodes near the bite, lymphadenopathy, and sometimes red streaks extending from the wound, lymphangitis, showing the lymphatic system is involved.
And the bacteria causing all this, is it one main type or that mixed bag again?
Almost always a mixed bag in dog bites. A polymicrobial party, you could say. Both aerobic and anaerobic bacteria are usually involved.
Who are the usual suspects?
Common aerobic ones include Pastorella species, beta hemolytic strep, Staphylococcus species, including MRSA, the resistant kind, and Staphylococcus intermedius. Also, Neisseria weevrii and Eikenella carotens.
And the anaerobic ones, the ones that don't need oxygen.
They play a big role, often found in over half these wounds. Things like actinomyces, Fusobacterium, Prevotella, and Porphyromonas. They love those deep puncture wounds where oxygen is scarce.
Making treatment complex again.
Precisely. You need antibiotics that hit both types.
Okay, here's where it gets, as you said, potentially really chilling. You mentioned Capnocytophaga canemorsis. That sounds serious.
It is. C. canemorsis is a major concern because while many dog bite infections stay local, this one can cause a fulminant systemic illness.
Fulminant meaning?
Extremely rapid, severe, potentially overwhelming. In susceptible people, it can lead to life-threatening sepsis.
The body's overwhelming response to infection.
Right, damaging tissues and organs everywhere. It can quickly progress to DIC, disseminated intravascular coagulation, a severe clotting disorder, and acute kidney failure. It's devastatingly aggressive. From a mild-looking bite to critical illness in hours sometimes.
That's terrifying. Who is most susceptible? Is it random?
Not random. There are very specific risk factors. People with impaired liver function, liver disease,
Okay.
anyone who's had their spleen removed, a splenectomy. The spleen is crucial for filtering bacteria like C. canamorsis.
Nice.
And anyone with any form of immunosuppression, maybe from medications like steroids or conditions like cancer or HIV, lack of a spleen is a major risk factor here.
And it's hard to diagnose quickly.
It can be. It's notoriously difficult to grow in standard lab cultures. Might take up to 14 days.
14 days. You can't wait that long.
Exactly. So clinicians often have to rely on suspicion and treat aggressively based on the clinical picture. Sometimes, rarely, you might see the bacteria inside white blood cells on a blood smear, which is an early clue.
Wow. Just thinking that a dog lick in the wrong person could lead to that.
Yeah.
It's sobering. What other systemic illnesses can dogs transmit besides these bacterial ones?
Well, the big ones everyone knows are rabies and tetanus, both potentially fatal without immediate post-exposure treatment.
Right.
Less commonly, tularemia, another bacterial infection, has also been reported after dog bites, so it's a spectrum of risks.
So bottom line, understanding this complex microbial world, including rare but deadly players like Capna cytophaga, is absolutely vital for doctors. It's not just a simple wound.
Precisely. It demands a comprehensive look. The animal, the patient's health, the whole range of potential microbial threats. It's like medical detective work with very high stakes.
Okay, let's shift gears from dogs to cats. Cat bites often seem less severe, maybe smaller wounds, but the data tells a different story, doesn't it? Deceptively dangerous.
Absolutely. This is a key point people often miss. Cat bites are less common overall than dog bites, yes, but they get infected much more often.
How much more?
More than half of all cat bites result in infection. That's significantly higher than the 15–20% for dog bites.
Wow, over 50%. Why such a high rate?
It's all about the teeth. Cat canines are narrow, incredibly sharp, like little daggers. They penetrate deeply.
Creating tiny, deep puncture wounds.
Exactly. Small on the surface, maybe, but deep inside.
So it's not the force, but the depth and precision. A different kind of injury.
Precisely. This deep, narrow penetration inoculates microbes much deeper, bypassing superficial defenses, often right into structures highly prone to infection, like joints or bones.
Ah, so that makes them more likely to cause.
Septic arthritis, joint infection, and osteomyelitis, bone infection, much more likely than dog bites, especially if the puncture is over or near a joint, particularly in the hand.
The hand, with all its complex little structure.
Exactly. Very vulnerable.
And who typically gets cat bites? And where?
Data shows women get bitten by cats more often than men. And like dog bites, the hands and arms are the most common locations.
Putting those joints and bones at high risk.
Correct. The location plus the deep puncture mechanism is a bad combination.
What about the bacteria in cat bites? Similar to dogs or different main players?
Some overlap, sure. It's often still a mixed infection. But the dominant player in cat bites is Pasteurella multocida.
Pasteurella.
Yes, a small gram-negative bacterium. It's a normal resident in the mouths of almost all cats, implicated in the vast majority of infected cat bites.
And it's particularly aggressive.
Extremely. Pasteurella infections tend to advance incredibly rapidly. Symptoms, severe inflammation can appear within just a few hours.
Hours, that's fast.
Very fast. Significant pain, redness, swelling, purulent drainage, and often adenitis, swollen, inflamed lymph nodes nearby.
That rapid onset is critical for people to know.
Absolutely. And interestingly, Pasteurella can also spread via respiratory droplets from animals, potentially causing pneumonia or bacteremia even without a bite. The median time for infection signs to appear after a cat bite is much shorter than for dog bites, maybe only 4–6 hours sometimes. Needs swift action.
What about other systemic illnesses from cats?
Similar to dogs, rabies and tetanus are risks, but a really important late consequence of cat bites and especially scratches is Bartonella henselae.
Ah, the cause of cat scratch disease.
Exactly. That usually shows up later, often with swollen lymph nodes. Less common, but tularemia and sporotrichosis have also occasionally been linked to cat scratches or bites.
So cat bites seem minor, but deep punctures, high infection rate, aggressive bacteria like Pasteurella leading to rapid inflammation, and a higher risk for joint and bone infections. Don't underestimate them.
Absolutely crucial takeaway. That small, deep puncture is precisely what makes them so hazardous. A direct injection route for bacteria into vulnerable spots.
Okay, moving beyond typical pets. Let's talk about other animal bites. Wild animals, occupational exposures. This must open up a whole new world of risks.
It certainly does. A whole menagerie of possibilities, really. These bites often happen in specific contexts. Farmers, lab workers, zookeepers, vets.
Or recreational. Hunters.
Yes, hunters, trappers, wilderness campers, even exotic pet owners. The guiding principle is the same, though. The infection generally reflects the animal's mouth flora, but the specific organisms get much more diverse.
Can you give us some examples? Maybe some surprising ones.
Sure. Feral cats, wild cats, big cats, they'll likely harbor Pastorella multicida like domestic cats. But think about freshwater aquatic animals,
Yeah.
alligators, piranhas.
Yeah.
Their bites might contain Aeromonas hydrophila, nasty bug, causes aggressive soft tissue infections.
And saltwater animals. Sharks, eels.
Injuries from sharks, moray eels, barracudas often associated with marine Vibrio species like Vibrio vulnificus. These carry a huge risk of rapidly progressing necrotizing infections.
Necrotizing meaning tissue death.
Severe tissue death can lead to limb loss, even death, very quickly if not treated aggressively.
That's incredibly dangerous, separate from the trauma itself. What about venomous snakes? Venom is bad enough, but bacteria too.
Indeed. The venom causes severe inflammation and tissue necrosis, creating a perfect environment for bacteria. The snake's mouth isn't clean.
What kind of bacteria?
A wide range. Pseudomonas aeruginosa, Serratia marcescens, Proteus, Staph epidermidis, anaerobes like Bacteroides fragilis, and Clostridium. So venom is one threat. Bacteria are another significant one needing antibiotics.
What about monkeys? Since they're primates, closer to us, similar risks to human bites.
That's insightful. Yes, bites from non-human primates often lead to infections similar to human bites because their oral flora is similar. But there's a huge specific risk, especially with old world monkeys like macaques.
Which is?
B virus, herpes virus simiae. Rare in humans, but if transmitted, it can cause severe, often fatal encephalomyelitis, inflammation of the brain and spinal cord. Needs very specific post-exposure management.
Wow. B virus. Definitely not something you'd think of first. Any other notable biters?
Oh, yeah. Hoofed animals, horses, pigs, sheep can transmit Actinobacillus lignuricea. And in the Arctic, bites from seals, walruses, polar bears
What happens there?
can cause a chronic pus-producing infection called seal finger, likely due to Mycoplasma species. Can be quite debilitating.
Seal finger. That's fascinatingly specific. Let's talk rodents now. Rat bite fever or RBF? That sounds different.
It is quite different, mainly because it often shows up after the initial bite wound seems to have healed, sometimes weeks later.
Weeks later? Okay. What causes it?
Two main bacteria. Most U.S. cases are streptobacillary RBF, caused by Streptobacillus moniliformis. It's a tricky gram-negative rod. The other is Spirillum minor, a spirochete, causing Sudoku, mostly seen in Asia.
Who's most at risk for RBF in the U.S.?
Usually lab workers handling rodents or, sadly, people living in rodent-infested housing, especially kids. It highlights a real public health issue, and that delayed onset makes diagnosis tricky if you don't ask about prior bites.
So, not an immediate infection at the site. What are the symptoms of the more common U.S. form, the streptobacillary one?
Incubation is usually 3 to 10 days. Starts with non-specific stuff. Fever, chills, muscle aches, myalgias, headache.
Flu-like.
Very much so initially. Then comes severe migratory arthralgias, joint pain that moves around, often hitting big joints like knees and ankles, followed by a characteristic rash.
What kind of rash?
Maculopapular, often on the palms and soles, can sometimes merge or look like little bruises. Pyrrhic.
And it can get really serious.
Oh, yes. Complications include endocarditis, heart lining infection, myocarditis, heart muscle, meningitis, pneumonia, abscesses in various organs. There's also Haverhill fever, same bug, S. moniliformis, but from contaminated milk or water, similar symptoms. Before antibiotics, RBF was often fatal.
With those vague early symptoms, differentiating it must be hard.
Very hard. It can mimic Rocky Mountain spotted fever, Lyme, leptospirosis, even secondary syphilis. The differential is broad.
How is it diagnosed then?
Ideally, by seeing the organism in tissue or blood, or culturing it on special enriched media. Serologic tests looking for specific antibodies, agglutinins, can also confirm it.
And the other form, Sudoku, from spirillum. How's that different?
Longer incubation, 1 to 4 weeks. You often get renewed pain and purplish swelling at the bite site, with lymphangitis and swollen nodes. Systemic symptoms are recurrent fevers, chills, headache. And the original bite might turn into an eschar, a dark, crusty lesion.
How's that diagnosed?
Usually by directly seeing the spearshets in blood or tissue, or sometimes animal inoculation.
Amazing detail. Very mastery level. One more unusual one you mentioned, NO1 bacterium.
Yes, CDC non-oxidizer group 1, seen after dog and cat bites. Usually causes local things like abscesses or cellulitis, but notably it can cause problems even in healthy people, sometimes progressing to systemic illness like bacteremia.
How's it identified?
Lab characteristics are similar to some Acinetobacter species, doesn't use sugar, oxidase negative, etc. Good news is, so far it seems susceptible to many common antibiotics. Aminoglycosides, beta-lactams, tetracyclines, quinolones, sulfonamides. Treatable generally.
Okay, let's turn now from animals to us. Human bites. They might seem less common, maybe less dirty, but they pose unique challenges, right? Higher infection rates even.
That's a crucial point, often overlooked. Human bites carry significant, complex risks. They happen in various ways, self-inflicted, bites to medical staff by patients, during fights, domestic abuse, even sexual activity.
And the infection rate is higher than animal bites. That seems odd.
It does, but yes, human bites get infected more often, around 10–15% or sometimes higher. It's due to our incredibly diverse and sometimes potent oral microflora, lots of bacteria, aerobic and anaerobic, some quite virulent. Our mouths aren't sterile, far from it.
What are the main bacteria involved in human bite infections?
Common aerobic ones are viridans, strep, Staph aureus, Eichinella rodents that one's key in specific injuries we'll get to, and Haemophilus influenza.
And anaerobes.
Very important here too, found in maybe 50% or more of these infections. Things like Fusobacterium nucleatum, Prevotella, Porphyromonas, Peptostreptococcus. Many of these make beta-lactamases.
The enzymes that break down antibiotics like penicillin.
Exactly. Makes treatment much harder. And hospitalized or debilitated patients might also have Enterobacteriaceae in their mouths, adding more resistance potential.
Beyond bacteria, can human bites transmit serious systemic diseases? Viruses?
Unfortunately, yes. Hepatitis B, hepatitis C, herpes simplex virus have all been transmitted. Also, bacterial diseases like syphilis, TB, actinomycosis, tetanus. The potential is there, especially with deep bites involving blood.
What about HIV? That's a huge concern for many people.
A very valid concern. While biologically possible the virus could be there, actual transmission via a bite is extremely unlikely. Yes. The conditions needed are very specific and rarely met. Post-exposure prophylaxis for HIV is generally only considered for bites with severe trauma, lots of tissue damage, and visible blood in the saliva. Otherwise, the risk is considered negligible, basically zero.
That's important context, very reassuring for many. Now, you mentioned Eichinella rodents being common in a specific type of human bite. Are you talking about clenched fist injuries or fight bites?
Exactly that, fight bites. These happen when someone punches another person in the mouth and their knuckle gets cut by the teeth.
Not an actual bite down, but an impact injury.
Right. And perhaps surprisingly, these are more common than actual occlusional bites. And they almost always lead to serious, challenging infections.
Why are they so uniquely dangerous?
It's the mechanics. The impact forces mouth bacteria deep into the hand's complex spaces, bones, joints, tendons.
And the hand position matters.
Critically, the hand is clenched during impact. When it extends afterwards, the contaminated tendons retract, pulling bacteria even deeper into those low oxygen spaces, perfect for anaerobes. Plus, people often delay seeking medical help for these injuries, maybe due to embarrassment or dismissing the initial wound. By the time they see a doctor, a nasty infection is often well established.
So, connecting the dots. High infection risk from diverse, resistant human mouth bacteria, specific bugs like Eichinella and anaerobes, plus that deep inoculation mechanism, makes fight bites extremely serious.
Precisely. They are a prime example of why immediate, often surgical intervention is vital to prevent devastating long-term hand function loss.
Given all these complexities, how do doctors approach diagnosing a bite infection? It sounds like a full investigation is needed.
Absolutely. It's a holistic approach, starting with incredibly thorough history taking.
What details are crucial?
Type of animal, provoked or unprovoked attack, exactly how long ago it happened. For animal bites, contacting public health immediately about rabies risk is essential.
Checking if the animal needs observation.
Yes. Or if it's a species known to carry rabies. For suspicious human bites, careful questions about potential domestic or child abuse are needed. And the patient's own medical history is vital: allergies, immunosuppression, splenectomy, liver disease, mastectomy, tetanus status.
So the background is as important as the wound itself. What about the physical exam? What are they looking for?
Meticulous examination, looking for signs of infection, redness, warmth, tenderness, pus, bad smell. Noting the wound type, puncture, laceration, scratch, and its depth. Assessing for involvement of deeper structures, joints, tendons, nerves, bones.
Documenting it carefully.
Often using diagrams or photos is very helpful. Then a general exam. Vital signs, checking for lymphangitis, lymphadenopathy, skin lesions elsewhere, functional limitations. For hand injuries, consulting a hand surgeon is essential to assess tendon, nerve, and muscle damage. It's intricate.
When are X-rays or cultures brought in?
X-rays or radiographs are indicated anytime you suspect bone penetration or retained foreign body like a tooth fragment. These can hide infection.
And cultures.
Essential for all infected wounds to identify the bacteria and guide antibiotics. Gram staining gives early clues. If there's an abscess, dead tissue, or foul smell, you need anaerobic cultures specifically.
How do they get the sample from small wounds?
A small tip swab carefully inserted deep into the wound. Interestingly, for uninfected wounds from animals other than dogs, cats, culturing might still be reasonable because the potential bugs are less predictable.
What if systemic infection is suspected? Fever, chills?
Then a white blood cell count, and critically, blood cultures are needed to check if bacteria are in the bloodstream.
This really highlights how crucial early, accurate diagnosis is. Missing something seems like it could have huge consequences.
It's absolutely paramount. The window for effective treatment can be very narrow, especially with aggressive bugs like Pastorella or Capnocytophaga. Early, accurate diagnosis guides everything wound management, whether to close it and choosing the right antibiotic. Delays allow infections to worsen dramatically deep tissue invasion, septic arthritis, osteomyelitis, sepsis. Outcomes get much worse. It's a race against time where precision matters immensely.
So once the diagnosis is made, what are the treatment strategies? Is it one size fits all?
Definitely not. It's multifaceted, varying based on bite type, severity, infection status, and the patient's health. A key, sometimes controversial decision is primary closure.
Stitching the wound up right away.
Yes. Many experts advise against immediate closure for wounds that are infected or have a high risk of becoming infected. Closing bacteria inside creates a perfect incubator.
So, if not stitching immediately, what's the approach?
Copious irrigation, flying heavily with sterile saline to wash out debris and bacteria. Thorough debridement, removing any dead or dying tissue, which bacteria love. Removing foreign bodies.
Then what? Leave it open.
Often, yes, initially. Wound edges might be approximated, but it's left open to drain. Delayed primary closure is common for riskier wounds. Leave it open, monitor, then suture it a few days later if infection risk is down. Small, uninfected wounds might just heal by secondary intention from the bottom up.
Any specific types? Always left open.
Cat bite punctures, definitely. Due to that high infection rate and deep penetration, they should almost always be left unsutured to drain.
What about facial wounds? Cosmetic concerns there.
Right, facial wounds are usually an exception, typically sutured after thorough cleaning due to cosmetic importance and better blood supply leading to lower infection rates. But timing matters. Wounds older than 12 hours on limbs or 24 hours on the face generally shouldn't be closed primarily and often need prophylactic antibiotics.
Okay, for established infections, antibiotics are a given. How are they chosen with that mixed bag of bacteria?
It's a careful choice based on likely pathogens informed by the biting species, gram stain, and ideally culture results. For dog-cat bites, you need coverage against Staph aureus, Pastorella, Capnocytophaga, strep, and oral anaerobes.
And human bites.
Need activity against Staph aureus, H. influenza, and those tough beta-lactamase-producing oral anaerobes.
What are the go-to antibiotics offering that broad coverage?
Combination drugs are often preferred. An extended-spectrum penicillin plus a beta-lactamase inhibitor like amoxicillin clavulanic acid or oapacillin sulbactam. The inhibitor protects the penicillin. These cover most bases reliably.
Are there alternatives?
Yes, second or third generation cephalosporins like ceftriaxone or ciproxim, but usually given with something for anaerobic coverage like clindamycin or metronidazole, as cephalosporins alone might miss some anaerobes.
What about penicillin allergies? That must complicate things.
Hugely, especially severe allergies. Choices become more difficult, often guided by lab sensitivity data as clinical evidence for alternatives is less robust. A common strategy is combining clindamycin, good for gram-positives and anaerobes, with something like trimethoprim sulfamethoxazole or a fluoroquinolone for other gram-negatives.
Any single drug options for allergy?
Moxifloxacin, a fluoroquinolone with anaerobic activity, might work alone in some cases, but a big caution. Azithromycin alone often has poor or variable activity against key bite bugs like Pasteurella, Eikenella, and Fusobacteria. Generally avoid it as the sole agent.
And MRSA, is that considered upfront?
Increasingly, yes. With community MRSA prevalence, empirical use of MRSA active drugs like trimethoprim, sulfamethoxazole, or doxycycline is often considered in high-risk bites while waiting for cultures.
How long is the antibiotic course usually?
Typically 10 to 14 days for established infections, but you have to monitor closely. If it's not working, rethink the diagnosis, look for other bugs, or consider surgery for drainage or debridement.
What about complications like bone or joint infections?
Osteomyelitis or septic arthritis require much longer therapy, weeks to months, to fully eradicate the infection.
Are there specific regimens for the really dangerous bugs like Cachnocitophaga or severe Pasteurella?
Yes. For C. Canamorsis sepsis, it's aggressive. 2 weeks of high-dose IV penicillin G or IV ampicillin sulbactam plus supportive care. Alternatives include cephalosporins, carbapenems, clindamycin. For serious Pasteurella infections, pneumonia, sepsis, meningitis, IV penicillin G is still the drug of choice. Alternatives are cephalosporins or ciprofloxacin. Penicillin resistance is rare in Pasteurella.
What about snake bites or seal finger?
Venomous snakebites antibiotics are controversial, but often recommended broadly, like ceftriaxone or epicillin sulbactam, due to high infection risk. Seal finger usually responds to doxycycline.
Now, what about prophylactic antibiotics? Given preventatively for bites that aren't obviously infected yet, is that standard?
It's debated, especially for bites presenting early, within 8 hours. Many early wounds do harbor pathogens and will get infected later. A meta-analysis for dog bites showed prophylaxis cut infection rates by 50%.
So it can help. But it's not automatic.
Not always. Without huge trials for every scenario, clinicians weigh factors: the animal species, wound location severity, and the patient's own health risks, comorbidities.
When is prophylaxis always advised or usually recommended?
Always treat human and monkey bites presumptively high infection rates. Usually treat most cat bites, especially on the hand.
What other factors push towards prophylaxis?
Severe injuries like crush wounds, any potential bone or joint involvement, bites on hands or genitals, host immunocompromised diabetes, liver disease, no spleen, compromised limbs with poor circulation, even prior mastectomy on the side of an arm bite.
How long is prophylactic treatment?
Shorter, typically 3 to 5 days.
It's fascinating how precise this gets. The level of detail for different scenarios shows that incredibly nuanced, tailored approach doctors need. It's not just the bite, it's the whole context.
Exactly. That holistic view, considering every detail, is what leads to the best outcomes. It's never one size fits all in medicine.
Beyond antibiotics and wound care, what other essential protections are needed after a bite? It seems like a layered defense.
Absolutely. Several vital measures go beyond bacterial infection. Rabies prophylaxis is critical.
How does that work?
It's twofold. Passive immunity via rabies immune globulin injected into and around the wound for immediate protection, and active immunity via the rabies vaccine series for long-term protection.
And deciding if it's needed.
Always consult local, regional public health authorities immediately. Rabies risk varies by location and animal. Wild animals like raccoons, skunks, foxes, bats are the main reservoirs.
But people often get treated after domestic animal bites.
Yes, because domestic animals might have encountered a rabid wild animal. And interestingly, more cats than dogs are reported rabid each year. Many places require reporting all animal bites for tracking.
What about tetanus? Always a concern with skin breaks.
Essential prophylaxis. Get a booster if you're immunized but haven't had one in 5 years. If never fully immunized, you need the vaccine plus tetanus immune globulin for immediate passive protection.
Any other general measures?
Yes, simple but important things. Elevating the injured area helps reduce swelling. Immobilizing the infected part, especially a hand or joint, promotes healing and limits spread.
And hepatitis B, is that a common bite risk?
Less common. Transmission via blood-free saliva is rare, but risk increases if blood is present or tissue damage is severe. Mainstay of post-exposure prophylaxis is the Hep B vaccine. Sometimes Hep B immune globulin is added for immediate protection in specific high-risk exposures.
So connecting it all, managing bites isn't just antibiotics, it's this comprehensive strategy. Rabies, tetanus, maybe Hep B prophylaxis, plus meticulous wound care, all tailored to the specific bite, animal, and patient.
It really underscores how a seemingly local injury can demand a wide array of medical knowledge and interventions to prevent potentially devastating systemic consequences, protecting the whole person, not just the wound.
And what a journey today. We started by really understanding the skin as that frontline defense and how a bite just punches through, opening up this hidden world of infection.
hmm We dove into the sheer scale of animal bites, especially dogs. There's specific microbial threats like that dangerous Capnocytophaga, and the often underestimated danger of cat bites, those deep punctures and rapid infections.
Then we explored the wilder side bites, from marine life, rodents, primates, each with unique pathogens like rat bite fever. And the distinct challenges of human bites, especially the fight bite, with its high infection rate and tricky bacteria.
Aiming for that mastery level view, we looked at diagnosis, the detailed history, the thorough exam, imaging, cultures, and then treatment, the nuances of wound closure, precise antibiotic selection based on so many factors.
Right, that highly individualized approach. And finally, the crucial broader prophylaxis rabies, tetanus, Hep B, showing that layered safety net needed after a bite.
This journey really reinforces the body's complexity, its vulnerabilities, and the constant battle our immune system fights against the unseen microbial world.
So as you, our listener, reflect on this deep dive, here's a thought. With so many pets and so many bites, what are the broader public health implications? Beyond doctors, what can communities and individuals do?
Mm.
Maybe it's about responsible pet ownership, understanding animal behavior better, safer interactions, and definitely knowing when even a minor wound needs prompt, informed medical attention.
Indeed. It's about empowering ourselves with knowledge that can make a real difference for our own health and those around us.
Absolutely. Thank you for joining us on this deep dive into the intricate world of infectious complications of bites. We hope you feel incredibly well informed, truly knowledgeable.
And ready to think critically about this topic, remember, the joy of discovery is continuous.
There's always more to learn. Until next time, stay curious.